and then at the end I have a little bit on methods of induction, because that's something that people have asked for. Okay, so anyone think of any complications of labour? Pop them in the chat or feel free to turn your mic on. Failure to progress, yeah. Postpartum hemorrhage, yeah. Postpartum hemorrhage. Shoulder dystocia, maternal fever during labour. So these are the ones that I've come up with. We're going to look at sepsis, yeah. So uterine rupture, shoulder dystocia, postpartum hemorrhage. We looked at that in not last week's, it was 2 weeks ago when I did a last lecture. So if you missed that, hopefully Anisha's uploaded some sort of link or something where you can watch that. But we went over postpartum hemorrhage last time. And antepartum hemorrhage last time, and then at the start of the term, I went over postpartum hemorrhage. So check those two out if you missed them. Cord prolapse, amniotic fluid embolism, and then preterm rupture of membranes, which we looked at last time in the antepartum hemorrhage lecture. I touched on that briefly. So there are other things that you guys have talked about which I've not really covered. These are things like failure to progress. Now, I think when I was there, UCL covered that really well, so I haven't touched on that. Let me know if they haven't done stuff on that and I can add it in. And also, breech position is I guess it's sort of a complication of labour, but you hope it's picked up before labour. We won't really touch on that, but it kind of comes up. But I can go over some at that if people want to. So we are going to start with an SBA. So this hopefully is the first SBA on Menti, which hopefully you can vote for. Please let me know if you can't. Okay. People have voted and it's okay.
Okay, cool. I posted it again just in case.
You don't have to vote if you don't want to.
If you haven't join. Yeah.
But... okay. So basically, there's a 35-year-old lady. She is G2P1. Anyone quickly, what does G2P1 mean? Pop it in the chat. Okay, well, it means that she's been pregnant twice and had one delivery after 24 weeks. So yes, Lizzie, you're right. Pregnant twice and had one delivery after 24 weeks. So she is currently in labour, like with her second child. So in a minute, she will hopefully be G2P2. She's had a previous C-section. She suddenly developed severe abdominal pain and there are signs of fetal distress on the CTG. So what is the most likely diagnosis? So on Menti, we've got most people going for uterine rupture. So the things you need to note here are the previous C-section, the fact that she is in labour right now, the fact that she has severe pain and the fetal distress. So that points to a diagnosis of uterine rupture. So well done. So does anyone quickly know what uterine rupture is? Any ideas? Okay, well, uterine rupture is basically a tear in the wall of the uterus. Now, it usually occurs during labour. However, it can occur at any point in pregnancy, but usually it occurs during labour basically just because there's a build-up of like all the pressure in labour because you're contracting, and that causes the uterus to tear. And the most common site of rupture, as you'll see in a minute, is the site of a uterine scar, which links into the previous, like what was the previous slide, the SBA, and also the risk factors that you have. So there's two different types. There's incomplete, which is when the myometrium is torn, but the peritoneum overlying the uterus is intact. So it's not like the uterus is torn, but it's not a complete tear all the way through. So the uterine content remains within the uterus. Basically, that means that the baby is still inside the uterus, but there is a tear in the uterus. Then there's complete, which is the myometrium and peritoneum are both torn, and this means that the uterine content, so basically the baby can escape the abdominal cavity. So this is more dangerous because it means that the baby is outside of the uterus and they are literally in the cavity with like the bowel, the liver, they're just floating around in the abdomen. And it also means that all the amniotic fluid and everything is now like burst and they're in the abdomen. And this is an obstetric emergency, as you can imagine. And the risk factors for this are previous surgery. So as I said before, it most commonly happens on the site of a scar. So C-sections are the biggest risk factor, and then also having a myomectomy, which is when you can like take out part of the uterus. So that could be treatment for like fibroids or something like that. And then excess oxytocin. So does anyone know what oxytocin is?
Or like a brief summary of what oxytocin does.
Yes, it's a urotonic. So basically, it causes the uterus to contract. And yeah, so as it improves the contractions of the uterus. So basically, it makes the uterus contract harder. And if you give too much of it, then it's going to like properly, that can, as I said, build up the pressure too much and cause the uterus to tear. So having excessive oxytocin with a previous C-section is a big risk factor. Having induction of labour, because most of the time with induction of labour, you end up needing to use oxytocin. And then having previous high purity, so having had many other children, because the more children you have, like the more stretch your uterus gets, and therefore the thinner it is, so the easier it is to rupture. And it is important to note that uterine rupture is very uncommon. So it's not that common, but it's something to look out for because it is very, very dangerous. So can anyone think of any symptoms you're going to get with uterine rupture? Shock, sudden pain, yep. Can you think of a pain radiating to where might you get? Fetal distress, yep. Shoulder tip pain, yes, Lizzie. Yes, Claudia. Oh, not Claudia, but yes, to the shoulder. So basically, you can get, these are the things that you would see. So you might have sudden onset, constant, severe tearing pain. So the pain is like a tearing pain, and it's constant. That's important to note. So it will continue between contractions. So before, the woman will have had contractions, stopping pain, contractions, stopping pain. When they get the rupture, they'll just have continuous pain. So that's when you know something's gone wrong. You'll get excess vaginal bleeding because they've now got a big tear. And then you might have slowing of contractions. So the contractions become slower and they also become less intense because the uterus just isn't going to contract anymore, or they might stop completely. So they might have this now constant pain, but they can no longer feel like the tightening of the uterus. And then with the constant pain, you can get shoulder tip pain, which is basically your diaphragmatic irritation. And then the bleeding, if it's really big, like large hemorrhage, then you can get signs of shock, so tachycardia, low blood pressure, that kind of thing. And then on examination, you will see loss of uterine tone, and because the uterus is not contracting anymore, you'll also get tenderness, particularly over the site of rupture. So if you palpate the abdomen, there'll be tenderness, and there'll also be like the uterus just won't feel contracted anymore. You'll get fetal distress. So on the CTG, late decelerations are characteristic of uterine rupture. And you can also get regression of the fetus up the birth canal. So if the head was like engaged or low down, it might suddenly go back up because the uterus is ruptured and the fetus has kind of like gone back up into the abdomen. And then you can also get palpable fetal parts. So on abdo examination, if there's complete rupture, you might clearly be able to feel like a fetal arm or a fetal foot or something, which you normally wouldn't be able to do. And it's because they're now outside the uterus and they are literally just underneath the abdominal wall. Does that make sense to everyone? Okay, so investigations. The definitive diagnosis for this is surgery. That is the main way that you diagnose it. You open up the abdomen and see that the uterus is ripped. You can do an ultrasound to show rupture, and you can also do like intrauterine pressure catheters, and you'll see that there's a loss of uterine tone, and the CCG will show distress. However, because it's an emergency, you shouldn't waste time with any of these. If you suspect it, you just go straight to surgery. Which leads on to the management. Can anyone think what the management might be? C-section, yes. C-section and repair. So what you do, firstly you resuscitate. So ABCD because the woman is likely to be in shock and have lost some blood. So you resuscitate, you need to make sure everything in A, B, C, D order is okay. And then you might initiate major hemorrhage protocol. So you might get O negative blood coming in, or she's already had group and save, that kind of thing would happen. And then you go take her to theatre for an emergency C-section. And you need to deliver the baby as quickly as possible, or they'll suffocate due to lack of oxygen because they're no longer in the uterus. So it's important that you get them out as quickly as possible. And then you basically repair the uterus. And if you can't, you do a hysterectomy, but obviously you try and repair. Does anyone know what the methods of prevention of uterine rupture would be? If you think about the risk factors, what would the main methods of prevention be? Okay, so the main methods are to reduce the rate of primary C-section. So firstly, to reduce the rate of C-section. So only take women for a C-section if they definitely need one. And then to be cautious with VBAC, so vaginal birth after C-section. So you can have, so most people will say if you've had 2 C-sections, then you shouldn't have a vaginal birth. They will say if you've had 1, you can try, but if you've had 2, you should not. So that's one method to do it. It also is not to induce women who've had previous C-sections. Some people won't do. And also to monitor. So with the oxytocin, you start low and you titrate up, so you don't just whack on a big dose straight away. So they're the methods to try and reduce it. Okay, the next complication we're going on to is shoulder dystocia. Does anyone know what this is? Or has anyone got any questions, firstly, about uterine rupture? Okay. Oh. Yeah, so Lizzie is right. The baby's shoulder basically gets stuck. So what happens is the shoulder or the shoulders, so normally it's one, but it can be both, become stuck after delivery of the head. So the anterior shoulder of the fetus will become impacted on the maternal pubic symphysis, and the posterior shoulder will become impacted on the sacral prominently, and that's less common. Usually it's the anterior shoulder that becomes trapped. So that's usually what you should remember, is it's the maternal the shoulder on the maternal pubic symphysis, and that is the most common cause of shoulder dystocia. So it is an obstetric emergency. So some complications for the mother are having a 4th or a 3rd degree tear. Anyone know what is a 4th or 3rd degree tear? What are those 2 categorized as? Yeah, so in 4th or 3rd degree tears, you have injury to the anal sphincter, and these tears should be repaired in theatre, and they need to be monitored and followed up by a obstetrician, or gynecologist, normally obstetrician. So you make sure that you them followed up basically. And you try and avoid tears in the situation by doing a episiotomy, basically. To try and stop them tearing, you should do an episiotomy. And then you also have postpartum hemorrhage, so if they're more likely to have internal trauma, which means they're more likely to bleed, and then also psychological trauma. So having a baby get stuck, as you can probably imagine, is quite scary, especially when they initiate the call the doctors do to get or the midwife does to get all the doctors in. Up to 20 people can run into the room and everyone will start shouting, and it's very scary for the woman. And for the baby, you can get brachial plexus injury, which is in the form of Ebb's palsy. And this usually occurs due to traction of the head. So basically when you try and pull the fetal head, that's usually what causes it. And the arm is abducted and internally rotated. And then you get pronation of the forearm. And usually this is reversible. Usually it's not permanent basically, unless the baby's had severe damage, in which case it will be permanent. But most of the time that is reversible. You can also get humerus and clavicle fractures, which, as you can imagine, aren't particularly nice. And then you can get a hypoxic brain injury, which is due to asphyxia if the baby is stuck for a prolonged period of time. Okay, so the risk factors for this are previous shoulder dystocia. So if you've had one baby get stuck, you're more likely to have another baby get stuck. Macrosomia, so being bigger than 4.5 kilograms, because it means you're a bigger baby and therefore more likely to get stuck. Having maternal obesity or maternal diabetes, because that means you're more likely to have a bigger baby. Induction of labour, prolonged labour, and instrumental delivery are all risk factors for shoulder dystocia, just because it's in induction of labour, it's because the labour's not started naturally. So like the birth canal might not be as open as it could be, that kind of thing. In prolonged labour and instrumental delivery, it's just because of the way the fetus is positioned. Yeah, and Nusha's just posted a little picture in the chat of the different types of palsies that babies can get. So there basically is a clinical diagnosis based on the fact that the shoulders have not delivered after the delivery of the head, so they should come out with the next contraction. You get failure of restitution of the head, so the head basically will remain in the OA position rather than turning into OT. So it will be occipital anterior rather than occipital transverse, basically. And then you get turtlenecking, so the head basically has come out of the birth canal. And then when the shoulder gets stuck, it like retracts back, so you can no longer see the neck, and the head like basically will move back up the birth canal. So another SBA. Oops, another SBA. So a 20. Oh, hold on. I think I need to change the question on Menti. Okay. Okay, I've changed the question, I think. Please let me know if I haven't. So there's a 25-year-old lady is in labour with her third child. She has gestational diabetes, and her previous baby was born at 4.3 kilograms. Sorry, the head is delivered, but on the next push of the shoulders are not, and the head pulls back slightly. What is the first thing you should do? So if you can, please vote.
If you can't, let us know.
Yeah, if you can't, please tell me, because I've done something wrong. Ooh. Okay, quite a few people are voting. We have a wide range of answers.
I guess they are all correct answers at some point.
They are.
So this is a mean question, but yes, this is quite a likely question.
It is, I thought, unless you've got a different answer to me, Anush.
No. I don't have a different answer to you.
Okay, so I'm going to go on to the answer unless anyone wants to vote. Last few seconds. Okay, so things to look for in this question is she has gestational diabetes, she has a previous baby, which is big, and the head is pulled back slightly. So we know the diagnosis is shoulder dystocia. So the answer is to call for help. Is that what you got, Anush?
Yeah, it's a bit of a sellout answer, but it's also definitely the correct answer. Yeah.
It is. So basically, well, this is the management plan. I'm hoping this is clear for you. So the first thing to do is basically the babies in these situations need to be delivered urgently because they're a really high risk of fetal hypoxia and therefore birth asphyxia and then hypoxic brain injury. So you need to deliver them quickly, and you need to discourage the mother for pushing. So the more she pushes, the worse it's going to be because the baby's stuck, and if she keeps pushing, it's not going to help. The baby's just going to get more stuck, basically. And you need to try and avoid downward traction of the head. So as we said before, that causes Erb's palsy. So you shouldn't pull on the head because that will cause damage. So you don't want to pull on the head, and you don't want the mother to keep pushing. So the first thing that is advised to do is something called Robert's maneuver, which is basically when the woman hyperflexes her hips, so she moves her knees up to her shoulders, and this basically widens the pelvic rim. And in like 90% of cases, the baby can be delivered this way, so it's non-invasive and it's helpful to do. So most of the time that works. If it doesn't work, you can apply suprapubic pressure, which is called a Rubin maneuver. Don't worry about all the names of these, just you need to know about like what you would do first, kind of thing. And basically you just apply pressure behind the anterior shoulder of the baby, so like behind the shoulders to release the shoulder. And and hopefully it will be delivered. And you can do this with McRoberts manoeuvre. So if the woman tries McRoberts manoeuvre, so she lifts her legs up and the baby's not being delivered, you can try to apply pubic pressure and see if that helps. And then you can try a different position, which is basically when the woman gets on all fours. And this also widens the pelvic rim, but it's not as commonly used as McRoberts manoeuvre. That is the most common thing to do. And in these situations, you should consider an episiotomy, because as we said before, the woman is high risk of tearing. So to avoid her tearing, it's easier if you do an episiotomy because it's controlled. Because if you use hair, normally they tear and they can tear along, as we said before, the anal sphincter and that kind of thing, which is not good. So if you cut instead, you have controlled where the tear is going to be, and you've controlled like the size of the tear. So usually that's much better to do. So you should consider large episiotomies for these. You need to make them large so you have as much room as possible, and it makes it easier to do. But you need to make sure that the woman has some sort of analgesia before you go giving her an episiotomy. So that's important to note. So then if those things don't work and you really want those to work, otherwise they're in trouble, you can try internal manoeuvres. So the one you use depends on the situation and the clinician, because some will have used some and some won't have used others. And they might have found that ones work better whenever they've tried it. So these are the different manoeuvres that you can try. I'm not going to go through them all because you don't really need to know them. You just need to know what you do to start with. So you need to know about McRoberts manoeuvre and suprapubic pressure. So you can deliver the posterior arm, you can do a Rubin 2 manoeuvre, you can do a reverse wood screw manoeuvre, or you can do the wood screw manoeuvre. These are just a combination of like sticking your fingers basically into the vagina and pushing the shoulder different ways and that kind of thing, and trying to twist the baby. And if none of that works, then you will consider these three things. So the first one is surgically breaking the clavicle of the baby. The next one is pushing the fetal head back into the pelvis and then trying to do a C-section. This is like hardly ever done, and I'm glad to see that no one voted for this option, because once the head's been delivered, it's very hard to do a C-section. Like, it's virtually impossible. It can be done, but it's very hard and it will have loads of complications. So you would try that if it's a last resort, because obviously you need to get the baby out, but you should, like, it's not really an option that's readily considered. And the other thing to do is a symphonotomy, which is basically when you break the cartilage of the pubic symphysis to widen the pelvis. Now, this is not really advisable either, because it's got lots of complications for the mother, because you are causing like damage to her. So you really want the first few steps to work, otherwise you're kind of screwed. So, the next question.
Before I was just going to say, like, a few of you might have like heard a mnemonic, like I think it's like helperer or something, which is quite a good mnemonic to remember the steps. But like, if you do use that mnemonic, just remember that the order of that mnemonic is no longer the recommended guidance. So like the order of that mnemonic is different to the order that is recommended by the Royal College, which is this order now. I don't know, Jess.
Never heard of that mnemonic.
I'll post it in the chat. If anyone wants it, you can have a look.
But most of the time you try McRoberts manoeuvre and that should work, and then you can apply suprapubic pressure. But you need to remember to call for help, because what if you're like a SHO or someone, and then other people will come in and you will end up standing there while I tell you what to do. So it's a proper emergency, and it's one of the scariest things that obstetricians come against. Okay, another SBA. Please vote on Menti, or tell me if you can't vote. I've done something wrong. So this is a 32-year-old lady in labour, has received artificial rupture of membranes. The CTG has picked up signs of fetal distress. A student midwife has done an examination and says that the lady is fully dilated, but she can feel the umbilical cord next to the undescended head. So has anyone got any ideas what this is? Oh, people are voting. It's okay.
I put the stupid mnemonic in the chat, if anyone wants it. Just
most of it's the same order,
which means don't use.
No, most of it is the same order. I mean, also you would consider an episiotomy first, but for example, if you try McRoberts manoeuvre and the baby comes out, then you do an episiotomy. So you might get her to put her legs up, try it. If you can't do it, then you do the episiotomy straight away. But you wouldn't necessarily go for it like straight away if you can try and get the baby out beforehand.
Yeah.
Oh, we have 50-50 for the answers, so someone else vote.
like it makes so much difference.
All right, well, we're those voted. We'll go on to the next. Oh, it's not meant to come with the answer, but there you go. So, in this situation, we have artificial rupture of membranes, which we'll go through in a minute, is a risk factor for this. Fetal distress, and the umbilical cord is next to the undescended head. So this is incomplete cord prolapse, and I'll come on to go. I'm going to go through the differences in a minute, but no. Okay, this is really sad.
What happened?
Well, the answer is showing on the next slide, which is really sad. I don't know how to. I can't fix that.
It's fine.
Okay, well, you can all see the answer, but this is the next question. So it's the same lady. What is the definitive management of the situation? Ooh, so the definitive management, okay, I'm not sure why it's gone funny, is a C-section. And we'll go through that in a minute. So she's got, what does anyone know what the diagnosis is? So we've got incomplete cord prolapse, and you're treating this with a C-section. So we'll go on to cord prolapse. I'm sorry that question messed up. So cord prolapse is that the umbilical cord basically descends through the cervix with or before the presenting part of the fetus. And it usually occurs when the presenting part is high, and this allows the cord to pass back down either next to it or below it, basically. So it is increased risk with artificial rupture of membranes. That is important to note because most of the situations in the SBAs that you will get will be like, this lady's had an artificial rupture of membranes, or this lady's come in for induction of labour and had artificial rupture of membranes, and now she has this. It is an obstetric emergency. And the complications are basically fetal hypoxia, which occurs due to occlusion of the cord by the presenting part. So obviously you squished the cord and then the blood can't flow through it, or vasospasm due to the exposure to the outside temperature. So if the cord is exposed, basically it starts to die. Well, it vasospasms, then the blood can't flow through properly, which is why it's bad because it's going to stop the baby getting blood flow before the baby's been delivered. So there are three different types really. There's cord presentation, which is the presence of the cord between the presenting part and the cervix when the membranes are intact. This is before the membranes had ruptured, but the baby is up here and the cord is here, but the membranes are intact, so the baby's not ready to be delivered just yet. There's incomplete, which is also called occult, which is the first picture you can see, which is what the SBA was describing. So the cord descends alongside the presenting part, but not beyond it, and this is after the membranes have ruptured. And then there is overt cord prolapse or complete cord prolapse, which is when the cord descends past the presenting part and is lower than the presenting part in the pelvis after the membranes have ruptured. Does that make sense? So risk factors for this, as I said, are artificial rupture of membranes and ECV. Does anyone know what ECV is? And can anyone think why it might be a risk factor? Also, I like the cheeky person who voted for C-section, even though they saw the answer. So ECV is external cephalic eversion, and it is done basically when the baby's breached and you literally from the outside push the baby round to try and make them from this way flip round. And basically you're moving, as Anya's saying, you're moving the baby and the cord around, so you can cause rupture of membranes you can cause cord prolapse because as you push the baby, you might push the cord as well, and the cord can then drop below the baby. So having an abnormal lie or breech presentation, especially footling. So footling presentation is basically when the foot is one foot is much below the rest of the body. Having a low birth weight because it means that the baby's not taking up much room, so the cord can get below them, or being premature because again the baby's not very big. Having multiple pregnancies, so it's a risk factor for the second or the third born child if they're being born vaginally, because the first one comes out and then the second one, because there's more room, the cord can just drop down. And then having polyhydrosis, because if you've got excess fluid, it gives a chance for the cord to the baby and basically keeps moving, so the cord can go below. So signs, there are no maternal signs. So it's not a complication for the mother, it's purely a complication for the baby. So you might palpate the cord on vaginal examination, which is bad, you don't want to touch the cord, and you'll notice fetal distress, you might get bradycardia on the CTG. Okay, management. Can anyone think about important steps in the management of this?
This is one of the strangest managements I've learned in the last 3 years.
Yes, Paul is right. You want to elevate the pressure off the cord. Does anyone know how you do that? Elevate the presenting part. Yeah, so to elevate pressure off the cord, you can elevate the presenting part. So the first thing to do is, again, call for help. It is an emergency, so you can call for help. And then you want to relieve pressure on the cord. So there are 2 different methods to do this. There's one that you normally do more than others. The first one is to reposition the mother. So you want to try like left lateral position with her head down on a pillow and her pelvis like elevated, so her hip under a pillow to be upwards. So basically that tries to if you try to move the mother like this, you're going to hopefully due to gravity, drop the baby back down, and that will relieve the baby putting pressure on the cord. You can also move the woman's knees to chest. So that's a similar position to the position in shoulder dystocia. And then you can put them on all floors, like Leanna said. Then the other thing to do is elevate the presenting part off the cord. So basically you can do this by literally putting your hand into the vagina and pushing the baby off the cord. And you don't want to touch the cord itself, because if you touch the cord, you can trigger vasospasm to occur. So you don't want to touch the cord. You just want to push the baby off the cord. And then you can do it by filling the bladder. So this is not you might do this if you're trying to it's done in the community, if this happens in the community, like in a home birth and you've got to transfer them to hospital, or if you're waiting to get someone to theatre and it's going to be a slightly longer wait than you want, then you'd fill the bladder. And basically if you fill the bladder, it stops the uterus contracting. Well, it decreases the uterine contractions, and then that will help stop pressing the baby, which will help stop pressure on the cord. But it's not, most of the time you will just manually move the baby and then reposition the mother. Does that make sense? And then you need to deliver the baby. So the method for doing this is an emergency delivery. So you need a C-section, and you can give chemolytics to reduce contraction of labour. So we talked about these last week in the antepartum hemorrhage lecture. So you can give them to reduce contractions, because as I said a minute ago, contractions can put pressure on the baby, which then puts pressure on the cord. So you can give them if you need to, but most of the time I'll just try and take them to theatre straight away. And you can try an instrumental delivery, but this is basically if the delivery is imminent. So if the baby's head is really low, and you think that the baby will come out within a few pushes, or with forceps or a kiwi, you can try it. And this is more commonly done if it's incomplete. So if the cord is next to the head, not below the head, you could try it. And the hope is that even if the blood supply decreases, because the baby will be out very imminently, there won't be much damage. Does that make sense? Sorry, I realise I'm whizzing through this quite quickly, so please let me know if I'm going too fast. Okay, so this is the last complication we're going to go through, which is an amniotic fluid embolism. So does anyone know what this is?
Or how it presents, I guess.
Yeah. Okay, so an amniotic fluid embolism is amniotic fluid and fecal cells basically entering the maternal circulation, and it's caused by a breakdown in the placental membrane. So the cause is unknown, and they think it's basically due to having strong uterine contractions if you've got excess amniotic fluid, or something that's disrupting the blood supply to the uterus. And it can occur at any time, but most of it, any time in pregnancy, but most of the cases occur in labour or within 30 minutes after birth. And it can also present, and I mean, it's very rare as it is, but there have been a few cases after terminations of labour, after C-sections, and after like maternal trauma, like so while someone's pregnant and they've like their belly's basically been hit. There are a few cases of that, but most of the time it will occur in labour. And it's very unpredictable. So even if you have risk factors for amniotic fluid embolism, it can happen to you if you have no risk factors. So as I said before, no one really knows what causes it. And even though there are risk factors, it doesn't really seem to have a strong correlation to the risk factors. So these are having multiple pregnancy, increased maternal age, having a C-section or induction of labour, and then uterine hyperstimulation. So that's, like we said earlier, being on like too high oxytocin levels. Having a uterine rupture has been shown to increase the risk of amniotic fluid embolism. Placenta previa, placental abruption, and polyamhydrosis because you have more amniotic fluid. So it is an obstetric emergency because it causes cardiorespiratory collapse and then hemorrhage for the mother. And it's very rare, but the prognosis is very, very poor. So the survival rates for having an amniotic fluid embolism are super, super low. And most cases are diagnosed on post-mortem, as opposed to like it being something that has happened and then they can revive the mother. So most of the time they diagnose it on post-mortem. And on the post-mortem, you find fetal squamous cells, debris, and amniotic fluid in the mother's pulmonary vasculature. So the symptoms, as Lydia said, you get shortness of breath and chest pain. You can get like chills, sweating, and shivering. You can get altered mental state, signs of shock, so like low blood pressure, high rate, and heart rate, cyanosis and collapse. You can also get DIC. So I think like every case of amniotic fluid embolism have DIC. Usually it presents within 4 hours, but most of the time it's like one of the first things to present. And it's just caused by like the reaction to the amniotic fluid where it being not where it's meant to be. You can also get fetal distress and then uterine atony, so the uterus basically stops contracting. So anyone know what the management for this might be? Any ideas? C-section, yep.
I love that. This is what I did in my exams. I just answered C-section for everything. Don't do that.
Oxygen and fluids. Yeah, so basically what you want to do is resuscitate the mother. So you want to do A, B, C, D, E. So that would include like giving her fluids and oxygen. So if they've got low blood pressure, you're going to start giving her fluids. If she's her sats are low or she's got severe shortness of breath, you start giving oxygen, and then you start basically CPR. A lot of the time these women will go into, as I said, like go into cardiorespiratory arrest, so they basically stop breathing. So if you're doing CPR, what you can try and do is you can do it on a left lateral tilt. So you basically lie the woman on her left, which relieves pressure on the uterus. Sorry, because the uterus is putting pressure on like the vena cava and stuff. So you put her on the left, and this hopes to like relieve pressure, so it improves venous return, which hopes to help basically. And then you do a C-section. And this is known as a resuscitative hysterectomy. So basically, it's a cut in the uterus, and it's known as resuscitative because you're taking out the baby, therefore the uterus is like shrinking in size massively, and also it's like blood supply is decreasing. And therefore, if you do that, it's a hope that that will help return to spontaneous circulation. So it will help the mother, like it'll help the heart basically start beating again when there's less pressure on the heart and the uterus is like not squishing the rest of the mother's organs anymore. Does that make sense? And if you have a look in the chat, Anusha's posted the position that you put them in.
Jess, also this is like an A to E that could come up, right, in OSCEs.
Yeah, it's probably. I mean, on a whole, amniotic fluid embolism is quite rare.
Yeah,
but
like
you
it's
could
unlikely,
get a mother that
but
stops breathing.
Yeah,
and it is one of the situations where you would do A to E.
Yeah.
Yeah.
Like, I think it would be a pretty harsh A to E because like they'll probably give you like PPH or something. That's more likely.
Okay. So we have one last SBA, which I haven't messed up yet. Please vote on Menti. I think I've changed it. Let me know if I haven't. So Lily is 39 weeks pregnant. This is her second pregnancy. She's been really struggling the last few weeks with pubic symphysis pain, which is making it difficult for her to mobilise and sleep. The doctor decides to induce her. This is a really rogue situation, but it was one I saw in clinic last year, so I just picked it. Pubic symphysis pain is a real thing that women experience, especially when they're heavily pregnant. I didn't know it existed, but you can get like special bands for it and everything that like women wear like round their waist that go under their bellies to help like lift their belly up, like their pregnancy belly up, to make it less painful and that kind of thing.
Also, before we go into induction of labor, I just have a quick question for the year fives. Does anyone know what Mendelssohn syndrome is? That's like it's like a one-line thing to know for exams. It's another labor complication, but you don't need to know a lot about it. You just need to know like a sentence about it. Yeah, so it's aspiration. It's like an aspiration pneumonia, effectively. It's an aspiration pneumonitis that happens it's more common in like pregnancy during delivery. Can happen due to general anesthetic and anesthetic agents. But yeah, it presents like a pneumonitis. That's all you need to know about it. You don't need to know anything else. Jess can correct me because I might be wrong.
Yeah, no, that's it.
Yeah, don't learn anymore.
A few more people, please vote. Also, I'm going to quickly add in, a couple of people have asked for me to do teaching on the CTG. I debated, but then most of my notes are literally from Geeky Medic, and they have like a quiz and everything on like the CTG and like different, like you have to answer like the bradycardia, have they got late decelerations, that kind of thing. So if you're struggling with it, I would fully advise to go and look on Geeky Medic, because if I was to give a lecture on it, anything I would say would literally just be from there. So I don't know if there's much point. But I mean, I can do an SBA with like some SBAs with it in, but I won't do like a whole teaching bit on it. So look on Geeky Medic if you want help.
I think it'd be a pretty boring lecture to sit through as well.
You just basically for the CTG, I think UCL just want you to be able to know what's worrying. So if you go onto Geeky Medic, it's laid out really clearly, and they also have that little quiz I talked about, which is really helpful to do to help you like understand stuff. So if you've asked for it, I'm really sorry. I probably won't be doing it just because Geeky Medic do it better than I would. Okay, enough people have voted on my quiz question now. So the answer is a membrane sweep. So well done to most of you who got that right. And so these are all different methods of induction of labour. There are some that are actual. Can anyone tell me which one's the actual methods of induction? Because there are some that aren't actual methods of induction. Which ones are the methods of induction? Any ideas? Yep, so the membrane sweep is a method of induction. So is a Cook's balloon, and so is giving a prostaglandin, so misoprolol is. The others are not necessarily methods of induction. They're like things that help induction. So they like augment induction. So they used to help it go along, but you wouldn't use it solely, if that makes sense. We'll come on to it in a second. So the first method we're going to go through is vaginal prostaglandins. So these are like misoprolol and propess, and they basically stimulate cervical ripening, and they can be used when the cervix is unripe. So even if the cervix is like zero dilated, you can give these because they'll help the cervix ripen as well, basically. And they have some degree of like helping contractions occur. They're not like you wouldn't use them as like a uterotonic, but they do like can help initiate the contractions. And they can be given intravaginally into the posterior fornix by either a pessary, which is like one dose over 24 hours. So you like put the pessary in and then take it out 24 hours later. So like for example, a woman can have it, you can put it in and then send her home and then bring her back the next day to take it out. Or it can go and there's a gel or a tablet which you put in as like a dose, and then you can do a second dose 6 hours later and then a third dose 6 hours later, but you hope after the first dose things will start moving. And quite often you need artificial rupture of membranes. That's what ARM stands for, and oxytocin infusion to be used alongside them. So quite often, although like giving ProPES will start labour, it won't do much else. It might start ripening the cervix, and then you need to do something else to get it moving. So the next method is a Cook's balloon. I don't think this is very commonly used, but I've put it in because I saw it used quite a few times at the Free when I was there. But I don't know how actually common it is. I don't know if that's just because one of the regs there just liked using it, so she used it a lot rather than giving the ProPES, which is, or the misoprostol, which is the most common, like prostaglandins are the most common method. So basically, this is a catheter with 2 balloons that goes into the vagina, and one balloon is on the uterine side of the cervix, and the other balloon is on the vaginal side of the cervix, and basically, like, the balloons are inflated, and it helps to basically ripen the cervix by, like, kind of forcing it open. Because it puts pressure on either side of the cervix, and that helps to ripen it and dilate it. So you leave it in the vagina for 12 hours and then take it out. And then after you've removed it, you often need artificial rupture membranes to help start labour as well. So you would put the balloon in, it starts to ripen the cervix, then you'll rupture the membranes and then hope that will get things going. If it doesn't, then you can also give an oxytocin infusion. And the last method is a membrane sweep. So apparently these are really, really painful and not very nice. And basically what happens is a glove finger inserted into the cervix, and they rotate it around the membranes, and it separates the membrane from the uterine wall. And that separation releases prostaglandins, and the prostaglandins hope to start labour, basically. So you separate them, and then that releases prostaglandins. But you can only perform it when the cervix is beginning to dilate. So if the cervix is 1 centimetre, you can do it. If the cervix is still not ripe, you can't do it yet. So they're also, does anyone know, these membrane sweeps are offered to every woman when they get to a certain gestation, but it differs if you've had children before and if you haven't. Does anyone know what those 2 gestations are? Okay, so does anyone know if you've had no children before, what gestation do they offer it at? Anyone? Okay, 40 weeks. And if you've had children before, they offer it at 41 weeks. And the idea is that they hope doing a membrane sweep will start labour. So if you've had no children before, they might do it at 41 weeks and then do it again. Sorry, they might do it at 40 weeks and then do it again at 41 weeks. But it can also be used earlier. So like the situation in the SVA, it can also be used earlier if you want to start labour for someone, but it's not that immediate. So this lady, you want to try and start her labour because she's obviously in pain. So you do a membrane sweep because it hopefully will start things moving. But it's relatively you don't have to bring them. You bring them into hospital to do the membrane sweep and then send them back home again until they're in labour, basically. Anisha, do you want to say something? Anisha?
I don't, but I don't. But I was going to say, to be fair, it's like the week cut-offs are some things that are worth learning closer to exams, like the specific weeks and stuff. It is it could be a question, I guess.
And the weeks you get, so you need to know when you get your booking test, when you get your anomaly scan, when you have the combined testings done, that kind of thing. You need to know between what ranges it's done and that. That's so when you can do amniocentesis and when you can do chronic villus sampling, because you do one before the other. So you should go through those.
Yeah. They won't they're unlikely to test you on it to the same rigor that PassMed will test you on it. PassMed goes a bit over the top, and they're like, oh, give the exact dates for these 7 different things. They're unlikely to do that, but they could somehow bring it into an integrated station, integrated question rather.
Okay, so then things to augment labour or augment induction. This will help it along. The first one is artificial rupture of membranes. So basically, you use an AM hook or a specific type of forceps, and what happens if you rupture the membranes? It releases prostaglandins, and that can start labour. So, for example, if you've given someone prostaglandins and their cervix is ripened and they've got things going, they might then rupture the membranes, which will release more prostaglandins and hopefully start labour. But this can only be done when the cervix is dilated or ripened. So that's why you have to do it after you're given prostaglandins, and you wouldn't do it on its own. So sometimes when you do it, if you've given prostaglandins or you've given a Cook's balloon and you do this, some people will go spontaneous into labour. Other times you need to give oxytocin infusion. So often it comes hand in hand with an oxytocin infusion, and it's used as an adjunct to in induction of labour if progress is slow. So basically, if you've done it and the woman's not progressing, you might use artificial rupture of membranes. And the other one is an oxytocin infusion, and this basically stimulates the uterus to increase the frequency and duration and intensity of the contractions after labour has started. So at this point, the woman her cervix has basically started to dilate, so like you're getting into labour, and she's either having contractions or she's not, and you want to start them. So you basically start low and titrate up until you get full contractions every 10 minutes. And this is to like avoid, as we said before, like risk of uterine rupture by having uterine overstimulation. So you don't want any more than 4 contractions in 10 minutes. That's bad if you get more than that. And it's used as an adjunct to induction of labour if progress is slow, but you can also use it if a woman goes into spontaneous labour and her contractions are just not strong enough, or she's getting like 1 contraction every 10 minutes and she's been in labour for like 4 or 5 hours, and you're like, this is not enough. So you might start it then to kind of get things moving. Does that make sense? Okay, so I don't have slides on these, but I've got notes on them that I'll quickly go through. But does anyone know when you would like induce labour? When would it be something that you do? So basically, you do it when the baby needs to be delivered, but they don't need a C-section. So you do it if there's prolonged gestation, which is what Anya just said. So they're more than 40 weeks. You would try and start labour basically. You also do it if they've had premature rupture of membranes. So usually, like, a woman will go into labour after her rupture of membranes within about 24 hours, but sometimes they don't. And if they don't, they're at risk of infection. So you will. If they're preterm, this is different. You don't do it. If they're preterm, you'll try and keep them in as long as possible and just give them antibiotics. If they're not preterm, you normally wait about 72 hours, and if they've not gone into spontaneous labour, you might then induce labour because you want to decrease the risk of infection. Some places will do it after 24 hours. They will start induction, but it depends. Also, if the mother's got a health condition, it means you need to induce them. So if they've got preeclampsia and they're not going into labour, but you don't want to give them a C-section because it might be unnecessary at this stage. If they've got high BMI or diabetes, you tend to induce them slightly earlier so the baby can stop getting bigger. So you might induce them at like 37 weeks to stop the baby growing anymore, so they will have a decreased chance of like shoulder dystocia and stuff. And then if they're twins, you induce them around 37 weeks, although multiples, more than twins, you don't tend to induce. You just go straight to C-section. And then if the baby has intrauterine growth restriction, you often induce them, which sounds counterintuitive, but you do it because the baby's going to just continue like not growing enough and not getting enough blood and not doing well. So you basically deliver the baby so that you can try and help it like externally. And if the baby's massive, you would also deliver the baby early because you don't want the baby, as I said a minute ago, to get any bigger. So a bit easier. Can anyone think of any complications of induction of labour? Well, I hope it's easier. Any complications?
Jess, do you have a list of indications for induction? That might be quite useful for them, actually.
Indications, I do. That was the indications, Anush. Oh,
yeah, I know. Do you have a written list?
Yeah,
that might be quite good. If you put it in the chat, because it's definitely, that's like one of the things that's definitely worth like learning, I would say. Just like indications for any procedure in both years 4 and 5 are generally worth learning.
Okay, they love any testing. Complications?
So yeah, that's it. Well, she finds out. Yeah, think of complications. We've spoken about one of them today.
It's all coming in orange, which I can't help. Sorry.
Oh, orange is fine.
Okay, so complications include failure of induction, so it just might not work. You can have uterine hyperstimulation, so that is a complication of oxytocin when you give too much, basically, and you get more than 5 contractions a minute. And then you can try and give like tolytics to like suppress the contractions, but if you can't like stop it, you might go to a C-section, or you might try like a forceps or a Kiwi delivery to get the baby out if they're low enough. And then you can get uterine rupture, which, as I said before, but that's very rare. You can get cord prolapse with artificial rupture membranes. You can get infection because you're inducing the labour, and the labour might take a while to start. So if you like rupture the membranes and try and start labour, the labour might take ages to actually they might take ages to actually deliver the baby. You can also get, apparently, research has shown that they're more painful. Induced labours are more painful than non-induced labours, like spontaneous labours, and it has shown to an increase in epidural requests in women, which is an interesting one. And then also there's increased rates of C-section and instrumental delivery compared to spontaneous labour, because obviously you're inducing labour and the baby might not necessarily be ready to come out. Okay, that is the end of our lecture. A tiny bit early. Has anyone got any questions? Anush, can you post the feedback link, please?